Bismillahirrahmanirrahim. Hello everyone, it's Ahmed Atwa speaking, and it's my great pleasure to be with you today to present this mini crash course about two important topics in urology, which are urinary retention and renal colic. The significance of these two topics comes from the fact that these topics are frequently encountered during clinical practice. So let's start with the first topic, which is urinary retention. When I ask my students about the definition of urinary retention, the usual answer will be its inability to void voluntarily. But this answer is incomplete because patients with anuria also has inability to void. But the main difference between retention and anuria is that patients with retention has a desire to void, but those with anuria has no desire to void. And this is due to the fact that those with retention have full bladder, so there is stretch of or stimulation of the stretch receptors, leading to the sensation of urgency. But those with anuria have empty bladder, so there is no stimulation of the stretch receptors and consequently no desire to void. So the complete definition of urinary retention is inability to void voluntarily in spite of the desire to do so. Before we proceed to the etiology of retention, I'd like to give you a swift resume of the nerve supply of the lower urinary tract. The lower urinary tract comprises the bladder and the urethra. The nerve supply of the bladder and the urethra includes the autonomic nervous system represented in the parasympathetic and sympathetic nervous system and the somatic nervous system. When it comes to the parasympathetic nervous system, it leads to contraction of the bladder with relaxation of the urethral sphincter, the internal urethral sphincter to be specific, represented in the bladder neck. So with contraction of the bladder and relaxation of the internal urethral sphincter, this will lead to voiding, which is one of the functions of the bladder. On the other hand, stimulation of the sympathetic nervous system leads to relaxation of the bladder or the detrusor muscle and contraction of the internal urethral sphincter represented in the bladder neck. And this will lead to storage of urine. We have to differentiate between the internal urethral sphincter and the external urethral sphincter. The internal urethral sphincter is under the control of the autonomic nervous system, but the external urethral sphincter is under somatic control, that's to say voluntary control. Getting into the details about the receptors included in these processes, sympathetic stimulation will lead to release of norepinephrine from the terminal nerve endings, with subsequent stimulation of beta-3 receptors in the detrusor muscle, leading to relaxation of the bladder. At the same time, there will be stimulation of the alpha-1A receptors in the bladder neck, leading to contraction. So there will be storage of urine. On the other hand, parasympathetic stimulation will lead to release of acetylcholine from the terminal nerve ending and stimulation of muscarinic receptors in the bladder wall, leading to bladder contraction. There are two types of muscarinic receptors in the bladder wall, M2 receptors and M3 receptors. The majority of muscarinic receptors in the bladder are M2 receptors, about 80% of the receptors. And the rest are M3 receptors. So 80% are M2 receptors and about 20% M3 receptors. However, M3 receptors are more active. And parasympathetic nerve endings induces relaxation of the bladder neck by indirect mechanism by inhibition of the sympathetic nervous system through the interneurons. And one of you will ask me, what is the clinical significance of all of these receptors? For example, if a patient with BPH, that's to say benign prostatic hyperplasia, he is warned to have cold medications containing sympathomimetics. Some of the cold medications in the market contains sympathomimetics like ephedrine, pseudoephedrine. They stimulate the alpha-1 receptors in the blood vessels, leading to vasoconstriction and relief of the nasal congestion. Nevertheless, they act on the alpha-1A receptors in the bladder neck at the same time, leading to contraction. So they will be difficult micturition up to acute urinary retention. That's why all these patients are warned from taking such medications. To the contrary, those patients with BPH, benign prostatic hyperplasia, are maintained on medical treatment in the form of alpha blockers. These alpha blockers block alpha-1A receptors in the bladder neck and the prostatic capsule, leading to their relaxation and consequently easy passage of urine from the bladder to the urethra. Another example, muscarinic receptors, as we said before, stimulation of muscarinic receptors leads to contraction of the bladder. There are some forms of drugs which are called anti-muscarinics, which are used to relax the bladder neck. These medications should be taken with caution because they might precipitate difficult micturition up to acute urinary retention. Again, there are beta-3 receptors, adrenergic receptors, and their stimulation leads to relaxation of the bladder, and alpha-1A receptors in the bladder neck, and their stimulation leads to bladder neck contraction. There are M2 and M3 receptors, and their stimulation leads to bladder contraction. About 80% are M2 and the rest are M3, but M3 receptors, as we said before, are more active than M2 receptors. Again, bladder has two functions, storage and voiding. The storage is mediated by the sympathetic nervous system, and the voiding is mediated by the parasympathetic nervous system. And now this is an important comparison between acute and chronic urinary retention. So let's start with acute urinary retention. The problem in acute urinary retention is that it's complete obstruction. So there is no flow of urine at all. The patient will not micturate. So he will present it to the emergency department with pain and tenderness. What's the difference between pain and tenderness? Pain is a symptom and tenderness is a sign. So pain from history and tenderness from the examination. And this patient usually will have no renal failure because he will be presented immediately to the emergency department and will be managed immediately by usually urethral catheter fixation and subsequent treatment of the cause. On the other side, patients with chronic urinary retention have partial obstruction. So he will not be presented with pain or tenderness, and the bladder will continue to be full of urine until the pressure in the bladder become high. And at this moment, the urine in the bladder has two pathways. The first pathway is to go downwards, causing what's called overflow incontinence when the pressure in the bladder exceeds that of the external urethral sphincter. And this is false incontinence, not a true incontinence, because the external urethral sphincter is intact. The problem is it's a high pressure reservoir. And the other pathway for the urine is to go upwards, leading to hydrourethronephrosis and deterioration of the upper tract and subsequent renal failure. As we mentioned in the beginning of the lecture, there is a difference between retention and anuria. The main difference is the desire to urinate. And from the previous slide, acute retention is accompanied by pain and tenderness, and as we mentioned before, pain is a symptom and tenderness is a sign. And the cause of the desire to micturate in acute urinary retention is that the bladder is full, but in anuria the bladder is empty, so there is no desire to urinate. The problem in patients with anuria is that they may have obstruction of the upper urinary tract, so the kidney is in danger and may end in renal failure. The management is different. So in patients with acute urinary retention, you have to manage them with urethral catheter fixation, and if it fails or contraindicated, you may proceed to suprapubic catheter fixation and eventually treatment of the cause. But treatment of anuria needs to emergently relieve the obstruction by means of urethral stent or percutaneous nephrostomy. We will discuss this later on. This is an example of the suprapubic bulge that you will see in acute urinary retention due to full bladder, and you can confirm your examination by renal and bladder ultrasound, which depicts a full bladder. This diagram illustrates the urethral stent, or what's called double J stent. It has upper coil to rest in the renal pelvis and lower coil to rest in the bladder to make the stent self-retaining. The stent is used to bypass any obstruction in the upper tract, for example, urethral stone or urethral stricture. And after normalization of serum creatinine, definitive intervention is advocated. Another example for relief of upper urinary tract obstruction is the BCN or the percutaneous nephrostomy. Percutaneous means it's fixed via puncturing the skin, and nephrostomy because the opening is reaching the kidney or the pelvic calcium system, so it's called nephrostomy. Now let's proceed to the causes of urinary retention, which are divided into mechanical and functional. The mechanical causes can be divided according to the site, maybe in the bladder, maybe in the urethra, or the prostate in males. There is an important category which is hematuria and clot retention, and I put it in a separate entity because of its importance. And now let's move to the functional causes, which include postoperative, drugs, neurogenic, and historical. Usually the postoperative causes are due to pain and using of some drugs or even injury of the pelvic plexus supplying the bladder. And drugs, as we mentioned before, drugs used in cold medications containing sympathomimetics and antimuscarinic drugs, and also some drugs used in anesthesia. Neurogenic causes, the most common cause is diabetic neuropathy, and historical, usually in females. So let's start with the mechanical causes. There are many causes, but I'll choose the most important and the most common causes to be more precise and meticulous. For example, causes in the bladder includes bladder neck obstruction. As you can see here, when you go by means of cystoscopy, you will find that the bladder neck is pinpoint like that. And to treat it, you perform two incisions at 5 and 7 o'clock, and this is the final uh, picture after relief of the obstruction. Then, in the prostate, the most important cause is benign prostatic hyperplasia. As this is an important MCQ question, the most common cause of retention in men above 50 years is benign prostatic hyperplasia or BPH. So this is a normal prostate and this is a enlarged prostate. And you can see here that the BPH usually arises in the transitional zone surrounding the urethra, leading to outflow obstruction. But in prostate cancer, it usually arises from the peripheral zone, so it rarely causes acute urinary retention. Regarding causes in the urethra, there are urethral stricture, like this picture. This is a normal urethra, this is a normal caliber, and this is urethral stricture. Now we are introducing a laser fiber uh, to perform incision at 12 o'clock, like here, to relieve this obstruction. Other causes include urethral trauma and pseudourethral valve, which is the most common cause of retention in boys. And finally, hematuria and clot retention. Regarding the functional causes, as we've mentioned before, postoperative due to pain, anesthetic drugs, and pelvic plexus injury, and drugs like the sympathomimetics used in cold medications and antimuscarinic drugs, in addition to anesthetic drugs, neurogenic, and the most common cause is diabetic neuropathy and historical. So, how to diagnose a case of acute urinary retention? Like any case, we'll start by history, then examination, abdominal and local examination. From the history, number one, you will ask if the patient is having the desire to urinate or not, to differentiate retention from anuria. So if the patient tells you that he has a desire to urinate, so he is having retention. Now I have to differentiate acute retention from chronic retention. So I will ask about pain. If the patient is having pain, usually is having acute urinary retention. But if he doesn't or she doesn't have pain, the diagnosis will be chronic urinary retention till proven otherwise. After that, I have to ask about the cause of this retention, because after emergency treatment of retention, I have to treat the cause. So I should ask the patient if he has is being maintained on medical treatment for BPH. He has previous history of stone passage, is maintained or certain drugs like antimuscarinic drugs or sympathomimetic drugs, and if he has any prior recent surgery or trauma. After that, we will proceed to abdominal examination to search for full bladder and tenderness, because the patient is having tenderness. This is usually consistent with acute urinary retention. For the local examination, it's formed of genital examination and digital rectal examination, or what's called rectal examination. For the genital examination, we usually inspect the external urethral meatus for meatal stenosis, and if the patient is uncircumcised, we search for phimosis, which is narrowing of the prepucial opening leading to inability to retract the prepuce. The second item is digital rectal examination, mainly for PPH and sometimes for prostate cancer. But as we mentioned before, that prostate cancer is not usually associated with acute urinary retention because it arises from the peripheral zone. Regarding the treatment, first of all, you have to fix a urethral catheter to bypass the obstruction. Uh, I'll attach a video demonstrating the process of urethral catheter fixation, but I want to confirm on the fact that the most common cause for difficult urethral catheter fixation is inadequate lubrication. So you have to make sure that you have done adequate lubrication prior to trial urethral catheter fixation. If a urethral catheter cannot be fixed, or if there is urethral injury, you can suspect urethral injury by the presence of blood on the urethral meatus, so you will proceed to suprapubic catheter fixation. And finally, we treat the cause. For example, if the patient is having BPH with failed medical treatment, so the treatment here will be transurethral resection of the prostate. And if the patient is having posterior urethral stone, endoscopic crushing, or what's called cystolitholebaxy. And now let's move to the second topic, which is renal colic. So when you review your textbook for the definition of renal colic, you will find that it's pain felt in the loin, referred to the groin, intermittent, no change by changing the position, may be associated with nausea, vomiting, and hematuria, blah, 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 blah. So please forget everything about this weird definition, and I'll explain it in a systematic manner. First of all, what's loin? It's the space between the last rib and the iliac crest, like here. The space between the last rib and the iliac crest. And usually the patient express it by flank pain, but you as a doctor say it's loin pain. And also there is a terminology which is called costovertebral angle, the angle between the last rib and the vertebral column. Note that any tenderness in this angle means that the patient either is having acute pyelonephritis or obstructed infected kidney. Like any pain you have studied throughout your study in this faculty, you have to memorize the mnemonic Socrates. S for the site, O for the onset, C for the character, R for the radiation, A for association, T for timing, E for exacerbation and relieving factors, and S for the severity. So, when you ask you about the site, it's in the loin or the flank. Then the onset is sudden. The character is usually colicky and sometimes dull aching. Colicky due to hyperperistalsis of the urethral smooth muscles, and dull aching due to stretch of the renal capsule by the back pressure caused by the stone. And the radiation, as we mentioned before, it's felt in the loin and referred to the groin. So it's referred to the ipsilateral testicle in males or the labia majora in females. Regarding the association, like any pain, any severe pain is associated with nausea and vomiting. And when the stone moves, this leads to mucosal injury and subsequent hematuria. Regarding the timing, it's intermittent. So when a patient told you that he is having a pain in his loin and this pain is continuous, you have to exclude renal colic. You have to search for another cause of this flank or loin pain. The pain does not change with postural changes. And this is an important item to differentiate renal colic from appendicitis or diverticulitis, because with appendicitis or diverticulitis, there will be peritoneal irritation. So the patient will try to keep silent as much as possible to avoid peritoneal irritation and subsequent pain. But in renal colics, change in position will not affect the pain. And of course, it's severe pain. According to the site of stone in the ureter, the patient will complain of different clinical pictures. For example, if the patient is having stone in the upper third, or what's called the lumbar ureter, he will have the classic renal colic as we have mentioned before. If the stone is in the middle third of the ureter, or what's called the iliac ureter, so the patient will have a picture of appendicitis on the right side or diverticulitis on the left side. And eventually, if the patient is having stone in the lower third, or what's called the pelvic ureter, he will have a suprapubic pain radiating to the tip of the penis in males. And usually, this pain is associated with frequency, urgency, and even urgency incontinence. When it comes to the differential diagnosis, there are many causes for the flank pain, because uh, most of the public, uh, when they have a flank pain, they usually think of uh, uh, stones, but actually, or renal colic, but actually, there are many causes like musculoskeletal pain or radiculitis, irritable bowel syndrome, appendicitis, diverticulitis, etc. And to differentiate, for example, the musculoskeletal pain is continuous, not intermittent like renal colic, and is usually increases by movement and decreases by rest. The pain caused by irritable bowel syndrome is usually relieved by defecation. Regarding appendicitis and diverticulitis, as we mentioned before, that the patient has signs of peritoneal irritation and he is trying to keep himself or herself silent as much as possible. Ectopic pregnancy is associated with positive pregnancy test, and lumbar disc prolapse is associated with other sensory and motor disturbances, usually in the leg, which is not present with renal colic. Regarding the investigations, they are divided into radiological and laboratory. First one is ultrasound. It is the first line investigation tool, but it's not 100% sensitive like the spiral and contrast CT. We usually use it as a first line investigation tool because it's inexpensive, radiation free, non-invasive, but it's operator dependent. Plain X-ray usually used for follow-up, not for diagnosis, because about 90% of urinary stones are radio opaque. Intravenous urography is rarely used nowadays, and the main and the most diagnostic tool is the spiral and contrast CT of the abdomen and pelvis, because it gives you the actual size and the actual number of the stones, the density in means of Hounsfield unit. It gives you also an idea about the anatomy of the pelvic calcial system, the condition of the contralateral kidney and the surrounding structures, so it can delineate other causes of loin pain. Regarding the laboratory investigations, urinalysis is important to rule out urinary tract infection and to also rule out crystalluria. And if there is crystalluria, we will know the predominant type of crystals is that calcium oxalate, calcium phosphate, urate, etc. If there is affection of the both the kidneys or upper tract, so you will request serum creatinine and electrolytes as well. When it comes to the treatment, hydration is encouraged, but please do not give IV fluids because IV fluids will induce more diuresis, more stretch of the renal capsule, more hyperperistalsis of the urethral muscles, and eventually more pain. Regarding the analgesics, non-steroidal anti-inflammatory drugs are recommended, and they are the first line medical therapy used, but you have to be aware of a nephrotoxicity. So acetaminophen or paracetamol is the first option in cases of high serum creatinine. Antispasmodic also may be used, and there are some medications containing both analgesics and antispasmodic like spasmofen. After that, you refer the case to the urologist to tailor the management plan for such case. Usually for renal stones, we start with medical therapy for certain types of stones, then shockwave lithotripsy. After that, endoscopic procedures, either percutaneous nephrolithotomy for renal stones or ureteroscopy for urethral stones. And open surgery will be the last option, and it is rarely done nowadays. This is an example of the machine used for extracorporeal shockwave lithotripsy. And this is an example of percutaneous nephrolithotomy. So a nephroscope is introduced by puncturing the skin, then dilatation of the tract till reaching the stone, fragmentation of the stone, then retrieval of the fragments to outside. And this is the example of the ureteroscopy to remove the stones, and finally open surgery. Now we reach the last station in our mini crash course, which is the questions. First one, the most common cause of urinary retention in men above 50 years is benign prostatic hyperplasia or BPH. Number two, the most common cause of urinary retention in boys is posterior urethral valve. The main difference between acute urinary retention and anuria is desire to urinate. The safest analgesic to be used in patients with renal impairment is acetaminophen or paracetamol. The last question, 95% of urinary stones are radiopaque by plain X-ray. Thank you for your attention, and kind regards and best wishes for you all. Thank you.